Howdy, folks. Welcome to the latest in 360 Edge's webinar series. Today, we're continuing the conversation about our partnership work with primary health networks and their commissioned services across Australia. And today, we're very pleased to share our work with Northern Territory PHN and Drug and Alcohol Services Australia, discussing the evaluation of the methamphetamine outreach program based in Alice Springs. My name's Richard Cash. I'm Head of Service Development at 360 Edge, and I want to give a big thanks to folks who've attended previous webinars in this series and returned. Perhaps to kick off today, in the spirit of reconciliation, 360 Edge acknowledges the traditional custodians of country throughout Australia and their connections to land and sea and community today, especially the Arunda people of Mabantua or Alice Springs. We recognise the ongoing impact of colonialisation and dispossession on First Nations people. We pay our respects to elders past and present and extend that respect and a warm greeting to any Aboriginal and Torres Strait Islander people that have joined us today. So, welcome, and just briefly, if you haven't come across 360 Edge before, we're talking about program evaluation, obviously, but it's worth mentioning we do a range of work across a number of areas, certainly service and program development, designing new programs, as well as workforce development, providing training to workforces, and systems and policy work, both alcohol and drug and some adjacent areas too. We're very keen on mental health as an example. What are we talking about today? I'm really pleased we're talking about program evaluation today, and we have a fantastic panel. Joining us from Darwin, we have Dr. Amanda Davies, who led this evaluation for 360 Edge. Now, Amanda has a formidable track record. She's established and run a range of drug and alcohol services. She's commissioned services as a PHN representative, and she's got a very strong research and evaluation focus, including service development and evaluation. I think there's probably a comment here about where the grass is green on the other side. Ask Amanda, because she's probably mowed the lawn on both sides of the fence. Joining us from Northern Territory PHN is Lloyd, the Executive Manager, Strategy, Commissioning and Integration. Big thanks to Ali, who stepped in today on behalf of Jill Yearsley, who's the CEO of NTPHN. Now, the PHN provided funding for this evaluation, and Ali's going to provide us with some insights about the importance of program evaluation from a funder perspective. Welcome, Ali. And of course, joining us from Drug and Alcohol Services Australia is Eloise Page. So Eloise, long-term Alice Springs resident and someone who's walked the walk in terms of delivering drug and alcohol services in Central Australia. She was previously Deputy CEO at DASA before taking on the CEO role, and she played a pivotal role in supporting the evaluation as head of the service. So a little bit of housekeeping before we dive in. You'll see a Q&A function in your Zoom controls. We're very keen to hear from you, and we've set aside some time at the end of the webinar where we can answer your questions and you can question our answers. So feel free to contribute a question for the panel and let us know what country you're on in the chat function. So without further ado, I'm going to pass the mic to Eloise, who'll tell us a little bit about DASA and the methamphetamine outreach program. Thanks, Eloise.
Hi, everyone. Thanks, Richard. I'm on the land of the Arunda people today, so I'll acknowledge them, their elders and their emerging leaders, some of whom I work with, very fortunately, here in Alice Springs. DASA's been around for around 40 years, operating in Alice Springs and in surrounding remote communities. We started off as a sobering up shelter and a small Aboriginal outreach team. We came from a grassroots community group who saw the need, and we've grown from there. And over that 40 years, we've expanded to include a residential therapeutic community called Aranda House, which is a mixed gender service for anyone from any cultural background. And we have a transition program for them to progress to, where they can work and study while still being supported on site at the therapeutic community. And we have an independent living program where people can further go on to for up to 2 years, where they sign a lease and pay their rent and are still supported to live independently, but they're doing it more and more on their own, working, and they can have their family there with them. We then have moved into the alternative to custody space. Here in Alice Springs, we run a facility for Aboriginal women, adult Aboriginal women who are at risk of or are engaged with the justice system. And that program's been incredibly successful, with polar opposite to results or outcomes proven by evaluation to what happens to women when they go to prison. So when they come to us, 80% of them don't reoffend. When they go to prison, 20% of them don't reoffend. So it's a completely opposite situation. So based off of that and that evaluation, we have now opened a similar facility on Groot Island, which is the northeast of the NT. It's very remote, and that's for Aboriginal men. We're yet to go fully residential, but that's coming. We run a drink driver education program, and we also run the methamphetamine outreach program, which is what we're talking about today. And that started a few years ago through the demand that was being seen through our other services, and that shift from alcohol or cannabis being our more dominant drug of choice here in Alice Springs. Methamphetamine was creeping in, mostly with non-Indigenous men. So some of our team who are already working at DASA, non-Indigenous people with lived experience, worked with the then CEO to get this program up and running. And what it is an intensive or assertive outreach program. The meth case managers work with our clients everywhere and anywhere within the community. That could be in a park or in the prison. It could be while they're in our service. It could be while they're just at home. They work with them to address all of the issues. It's a whole person approach. It's court support. It's housing support. It's pre-release support, post-release support. It can be things with their family, around their mental health, their physical well-being. It's very person-centered, and it wraps around. It fills the gap. It's kind of like pouring water into a glass of rocks. That's what the methamphetamine outreach team do. They just pick up everything that no one else in our community wants to do. That's the simplest way to explain it. And they don't judge. They've all got lived experience, and they walk beside people to get them to a better place in life without an expectation or judgment on those individuals.
Ali, I might turn to you to tell us a little something about the NTPHN's the importance of evaluation.
I think, can I just check, Amanda, you're on mute?
No, sorry, it's still you, Eloise.
Okay, so why we wanted to evaluate? Well, everyone at the service was so proud of this program, like many of our programs. Everyone kept talking about how wonderful it is and all the outcomes it achieved. But then when I would talk to people, funders, for instance, the PHN who fund it, etc., about how wonderful this program is, and it's only 3 case managers and they're doing all this work and we need to expand it, people would say, well, what's it achieved and how? What's the magic? What's it really been doing? What are the numbers? What's the demand? How do you know? So all these questions were coming out. And then there was the fact that some of the long-term staff had moved on and another one was potentially moving on. And how were we going to maintain this unique program if nothing was written down? And not to say that nothing was written down, but the essence of the program or the how to do the program wasn't written down. And we wanted to be able to prove that what we were doing worked, not just say that what we were doing worked. We knew it internally, but we wanted someone else from outside to look in the bottom drawer in the kitchen with all the stuff and take it out and pick it all apart and say, hey, yeah, you're right, this is working. but you could do it better if you did it this way, or you could add this or take away that. We needed that unbiased set of eyes. And so we started talking to PHN about that. We wanted to know, we wanted the barriers acknowledged and maybe some ideas about how to challenge or tackle those barriers. And we wanted the staff in the team to feel validated as well. So this process, while maybe scary at first to people, especially the people who are actually who've got the heart and soul of the program, now they feel such immense pride because these people with these huge experiences and qualifications, Amanda and Richard, have told them what they're doing is fantastic, and they've actually mapped it to show us what it looks like, what the journey for a client looks like, and what it is that actually gets done in that process and how the program works. So that's what we wanted to do. We wanted to capture the essence of the program, create a program logic. And we wanted to be able to make the program sustainable beyond the individuals when they go and take that knowledge or those unique skills with them. And ultimately, we really wanted to hear what our service users really value about the program, what they really thought. And that's what we got.
So now it's over to you, Ali. Apologies for jumping in before.
That's okay. Thanks, Richard. And thanks, Eloise. I think, the question there is what's in it for PHNs, and Eloise has articulated and wrapped it up nicely in why evaluations are important. But I guess from a commissioning agency perspective, when we're, and I know I don't need to explain how it all works to everybody, but typically, we're not funded for evaluations, but when we have the opportunity, we do take them to evaluate programs to give us a number of key points. And one is to understand and demonstrate the evidence of how a program is performing, but it's not just about performance. It's kind of ensuring that what the program is doing is actually meeting what the community needs, that it's fit for purpose, that it's driven by the service provider in their consultation with the community. And Eloise spoke about, the increasing demand that was occurring in her community. And so the evaluation, as we work through, when we do, I guess, business as usual contract management, and we require reporting, and typically they are quarterly reports or 6-monthly reports, they may not contain all the rich data that we actually would want. And so that's where we think evaluations come into play. They are a deeper dive into the program. They're a deeper dive into how things are performing. And they demonstrate and give us an indication of the barriers, as Eloise has pointed out, and where we might be able to support in addressing those barriers. The other key component, I guess, for us is to help us understand how we might future plan and how we would then join Eloise and other organisations like hers in joint advocacy where we need to. In the same way that the PHN may be asking Eloise for evidence, the Commonwealth, who we're funded through, would also ask the same thing. If we wanted to continue funding a program like this, we would also need to provide evidence to our funding body. So it's kind of closing the loop on that whole commissioning piece. And I guess just going back to the data, I think what evaluations also gives us is it allows us to understand whether or not we've been asking for the right things and whether we've been measuring the right things. And if we haven't, then that's our opportunity to get it right the next time. When I say that, I'm talking about things like outcomes. What are the outcomes that are being achieved? And I think as PHNs, it's important that we acknowledge that outcomes don't necessarily need to be clinical outcomes, that we embrace social outcomes. Outcomes to a community might be different to outcomes needed for another community. So I really think that the evaluation and the information that comes through those gives us the ability to have that wraparound lens when we're future planning and when we're considering ongoing funding for programs.
Thanks, Ellie. Okay, so it was a great pleasure for Richard and I to work on this project in Alice Springs. It's such a unique and special program, and it was lovely to be invited to work with DASA to do this work. So I guess we used a six-stage approach to doing the work. It was really important in the first instance to pin down the scope of work and confirm what the intention was, what were the desired outcomes for DASA, and really kind of define that clear scope for the evaluation. The next really important step for us was to have a collaborative design session to really nut out all the key elements of the evaluation. So we all sat in a big room down at DASA with DASA leadership, the caseworkers. I had some colleagues online. I was lucky enough to be in the room in Alice Springs, and we had the quality and compliance person as well. And we just nutted through the methodology. We confirmed the methodology. We identified all the available key data sources. We drafted and confirmed the key evaluation questions. And I guess importantly, we wanted to work out our approach to engaging with service users. Obviously, service users in Alice Springs, or anywhere, but in Alice Springs, are very vulnerable and sensitive. We wanted to kind of be, as evaluators, arm's distance, because we're not therapeutically involved with the service users. So we nutted through the approach that we would use to ensure that we were able to get insights from past service users and current service users. I'll quickly just mention what we did. We trained another DASA staff member who was not involved in the Meth Outreach program to be able to do those interviews. We worked with the caseworkers and DASA leadership to develop the surveys to ensure they were in language that was simple and easily understood. They weren't complicated by our academic brains, and that they were going to be fit for purpose and ensured a really safe and ethically sound process. So we mapped all of the operations that inform the methamphetamine outreach service activity day to day. And through that, we developed a program logic, which everybody here today would know that that's a visual representation of all the moving parts for the evaluation, for the program. And we've got a copy of it at the end of this presentation. And it's very busy and it's very colourful, but we just wanted to give you an idea of what that would look like. We also undertook a document review. We looked at things that like assessment protocols, referral processes, operational documents, the service agreement, and some compliance reports. We undertook a number of consultations internally because, as you saw, there's a lot of services that DASA is running. So there's a lot of internal referral pathways that the methamphetamine outreach team use to support their clients when they want to step up their support. And also we know that people who run those other programs at DASA refer into the methamphetamine outreach program. So we wanted to get those insights as well. We consulted with external stakeholders, which included clinicians from Alice Springs Hospital. Obviously, the emergency department at Alice Springs Hospital is a very busy place, and a lot of people use that pathway into AOD treatment. And there's an quite extraordinary addiction medicine specialist in Alice Springs, and we had we were lucky enough to be able to consult with him. And then we crunched all the data, synthesized it, and we mapped the data against all the key elements of the program and the evaluation questions. And then we came up with a very comprehensive evaluation report. But I think importantly, we developed opportunities and recommendations that were in line with the program's needs. So they were aimed at service improvements, but they weren't so kind of blue sky thinking that they were never going to be able to be achieved in the context of a small methamphetamine outreach program in Alice Springs. So that's the approach we used. I'm just going to talk quickly through some of the findings because I want to leave enough time for questions. Okay, so as I said, we mapped all of the core elements of the program against all the findings from the consultations and from the data analysis. At the time of doing this evaluation, DASA was transitioning from quite a historic data management system into an updated data management system. So that did impact the data quality for some things, but we also managed to get hold of the minimum data set data. So we mapped all of that against the core elements of the program, and we also aligned that with best practice. So we found that there was lots of alignment in terms of the pre and post-release support for people coming out of Alice Springs prison. We identified the brief counselling and harm reduction interventions that are employed by the caseworkers. They also use a range of strategies for their relapse prevention. They do high-level and comprehensive advocacy for their service users, psychoeducation, pro-social activities, and vocational training and employment support. And I'll get to a couple of quotes on the next slide, which really reinforce the importance of people being able to move on with their lives. We identified a number of enablers and barriers. So many of the enablers related to DASA's reputation, long-term reputation, very positive reputation. Another enabler is the priority access to other DASA services, really great relationships with local service providers. And this program is really perceived to have specialist skills that no one else in Alice Springs have. Many of the services in Alice Springs will not work with people who are still using drugs. They may work with people who are still using alcohol, but they definitely don't want to work with people who are using methamphetamine. And they're not specialist harm reduction clinician support workers. So the specialist nature of this work was really identified as an enabler. And in that way, it fills an important and critical service gap in Alice Springs. So the barrier is obviously methamphetamine users across the country are a highly stigmatized group of drug users, but so that is amplified 100 times in a small town like Alice Springs. So stigma related to methamphetamine users is a real barrier for engaging methamphetamine users into care and support and treatment. Also, these people, the clients, have a really high level of unmet needs. So they might have kind of ducked in and out of the health system or the justice system over many, many years. And so they come into the methamphetamine outreach program with a high level of unmet need. They are perceived to be, true or not, as incredibly complex. But it's also the limitations of having 3 caseworkers working with clients who have high levels of unmet need in a service context that's already stretched to the max. So that is a barrier to doing all the work that everybody wants to do and achieving some of the outcomes that people want to achieve when they're engaging with the meth program. So I think it basically kind of boils down to a demand versus capacity situation, and we've made some key recommendations about upscaling the monitoring of this program to ensure that that data is better captured into the future. Richard, do you want to move on to the next slide? So these are just a couple of quotes that we wanted to showcase, I guess, about the really great feedback that we got from service users. And in summary, these quotes kind of say that we got the right care at the right time, in the right place, in the right way. So I think these are really telling. Currently in a mining job, my family and kids are really grateful, doing an apprenticeship down south. So I think there's really great feedback there, and that was really consistent across the board. And so these are the 3 key areas that we made recommendations about. We feel like because we mapped all the key elements of the program, we think there's enough there now, and a program logic, there's enough there now to actually inform the development of a model of care. So all the key ingredients for a model of care, most of the key ingredients already have come through this evaluation. We've made a really important recommendation to develop a model of care dedicated to this program, particularly as Eloise said, this program has developed organically. Staff are moving on. It's time to kind of consolidate all of those insights and all of that great work into a document that depicts all the work, and it will give fidelity to the program and also help to induct new staff into the program and guide their work. We've made some key recommendations about building the capabilities and the robustness of the administration systems that support delivering services. And we've made some key recommendations about building capacity around outcome monitoring. We think that through the evaluation framework that we developed for this piece of work, there's a lot in there that can be tweaked into a monitoring framework so DASA can do that themselves. They don't need us to come in and develop that framework. All the key ingredients are now there in between the findings and the evaluation framework that we developed. So we're just going to quickly land on the service user journey, which was an additional asset that we don't always develop for evaluations, but because it was important to really kind of break down the key elements of this program. And we also included a data management around key service activity and key timeframes for doing that data management. So this is, I won't go through that because we won't have any time for questions, but it's a really important visual representation of the program. And then finally, we developed a program logic, which I call often Richard's baby because he's really good at developing program logics. And we'll just leave that up there while we have a few minutes for some questions.
What an excellent idea, Amanda. And I just have to do a very quick shameless plug. If you're interested in seeing how program logic models and service user journeys and program elements turn into a model of care, we've actually got a webinar next Thursday where we're going to go through developing models of care for frontline services. But these are the kind of key descriptors. What do we do and what do we expect is going to happen as a result of all of the activities in a program? So it's probably of the very obvious cue, maybe to pose to you, Eloise. But what's, I guess, the question coming through is what's next for DASA in terms of taking the evaluation results and building some of these recommendations into program operations?
Yeah, so our new incoming therapeutic lead will be tasked with leading this project and developing an action plan, which we would then, of course, share with the PHN as part of our annual processes so that they know what we're trying to do, but also assessing which of the recommendations or barriers or opportunities we can work with or can change and which ones maybe have to be parked for later, what's realistic, what's not. I think now that we've proven that the importance and the need around the program, that we have to look at should it grow, should it operate in a more responsive way, as in it's currently an 8 till 4 setup with 3 workers, and methamphetamine or any substance use doesn't just happen between 8 and 4. Unfortunately, and particularly with some of our methamphetamine users, they've got full lives outside of their methamphetamine use that they need to fit in with their checking in with the outreach team. So to be more flexible, but also the data shows there's been a significant shift over the past couple of years from it being non-Indigenous men using methamphetamine in Alice Springs to Indigenous men, and there has been an increase in injecting use as well. So we're seeing a cultural shift, and I think it's time we talk to other funders around money from Aboriginal funding sources for a dedicated Aboriginal methamphetamine outreach worker. Perhaps that could be a development role within the organisation, someone we can grow. We have a high number of Aboriginal staff and lived experience staff. We could really build that team and maybe move to a more flexible model of delivery with starting earlier, finishing later, but to keep it safe, having 4 staff. We can't do that at the moment because of there only being 3 workers, and we need 2. They work in pairs. So that's the aim, is to keep meeting the needs that are out there in our community.
And conscious we've almost run out of time, but there is a question in the chat from Karan. What tool does DASA use to measure service user outcomes? And I'm going to say it's a few, Eloise, but maybe if you've got a brief answer to that question for our attendee.
Well, I think the best feedback we've got is actually from this evaluation, to be honest. Otherwise, it's, we have our end of treatments and mid-treatment survey questionnaires that we've developed and satisfaction surveys, but we definitely need to improve those tools, and that's come through in this process as well.
Yeah, maybe it's something we can pick up in next week's evaluation, because again, building measures in at the time points where they're relevant in terms of positive outcomes for service users is a big part of the data management part of service user journey. Not just where will they be at various points, but what are we on the hook for in terms of data collection? Again, gives a bit of a meaningful set of data that would be useful for PHN purposes as well. But folks, I'm conscious we're a minute over. I want to say a huge thanks to our panel for coming together and sharing this. I think it's probably worth saying, a bit of an elephant in the room here, that evaluation can be a bit scary. The benefit of evaluations we've heard is transparency for all parties about how programs work and the extent to which they're effective. But it can be a bit of an intimidating process. So we were very happy to partner and really happy to share our work with the broader community. A big thanks to everyone for coming along today, and we hope to see you back again next week. Cheers, folks.